Hello, everyone. Welcome to the Green Top Guidelines Summary of the Day. We are here today to have a discussion upon the care of the women presenting with suspected preterm pre-labor rupture of membranes from 24 weeks of gestation. The Green Top Guidelines 73, published in June, year 2019. The preterm pre-labor rupture of membranes complicates up to 3% of pregnancies and is associated with 40% of preterm births. The PPROM can result in significant neonatal morbidity and mortality, primarily due to prematurity, sepsis, cord prolapse, and pulmonary hypoplasia, and also associated with chorioamnionitis and the placental abruption. The median latency after PPROM is 7 days and tends to shorten at the gestational age at PPROM occurs. The key recommendation, box 1, is very important regarding the diagnosis. The first examination step is speculum. Having the insulin growth factor or the placental alpha microglobulin, consider performing if at all the speculum examination is non-contributory. Also, some important points regarding the combination of tests is important for your exam. The diagnosis in terms of the nitrazine is not recommended at all. Here, the assessment is a combination of the clinical assessment and the maternal blood test. The C-reactive protein, the white cell count, and the fetal heart rate should be used to diagnose the chorioamnionitis in women with PPROM, and these parameters should not be used in isolation. C-reactive protein has a sensitivity of only 68.7% and the specificity of 77.1% in diagnosing histological chorioamnionitis. Erythromycin should be given for 10 days following the diagnosis of PPROM or until the woman is in established labor. Erythromycin 250 mg 4 times a day for 10 days or until the woman is in established labor, whichever is sooner, is recommended in NICE guideline. Penicillin may be used in women who cannot tolerate erythromycin. Alternative antibiotic regimens have been investigated. Coimoxiclav should be avoided as it is associated with an increased risk of neonatal necrotizing enterocolitis, and antibiotics should not be given unless the diagnosis of PPROM is confirmed. You have to remember the role of the antenatal corticosteroids, when to offer, when to consider, a very important single best answer. In women who have PPROM and are in established labor or having a planned preterm birth within 24 hours, intravenous magnesium sulfate should be offered between 24 and 29 plus 6 weeks of gestation. The tocolysis in patients with PPROM is not recommended. I repeat, the tocolysis in patients with PPROM is not recommended. The decision to offer outpatient care to women with PPROM should be made on an individual basis, taking into account the markers of delivery latency. The optimal method of monitoring to predict the adverse fetal outcome after PPROM has not been determined. Women whose pregnancy is complicated by PPROM after 24 weeks of gestation and who have no contraindications to continue the pregnancy should be offered expectant management until 37 weeks. Timing of the birth should be discussed with each woman on an individual basis with careful consideration of patient preference and ongoing clinical assessment. In a subsequent pregnancy following PPROM, women should be cared for by an obstetrician with an interest in the preterm birth. Some important exam points from this guideline is the definition of PPROM, the gestations to remember, when to offer and when to consider the corticosteroids, tocolysis, and magnesium sulfate. What is the treatment plan for a patient at certain gestations? Best of luck from the entire team of RFA tutors. Thank you very much for being with us today. Until we meet again, take very good care of yourself. Bye-bye.